So in terms of tips and tricks, the question always comes up. So, we've had a bug bite. Is this cellulitis? Is this just local reaction, allergic reaction?
Soft tissue edema.
Soft tissue edema. So exactly, you cannot tell the difference between cellulitis and edema. You're going to have to use your clinical cues to help tell you what that actually is. The other thing is make sure that you're not cutting into anything that you shouldn't be. So putting on the color, making sure that you're actually looking at your soft tissue and not your lymph nodes or your vessels. So this is what I'm talking about here. So on A, the reason we talk about visualizing all of the borders is because, so we're having some sort of abscess here, an anechoic structure that then goes down. So when it goes down, showing a fistula, which is really important why you want to see all the borders. Things that you might not want to cut into in the emergency room, you want to call general surgery for, be a lot of fistulas. So that's why you want to see all your borders. In B, here we have a bit of soft tissue swelling around, and then we have this hyperechoic structure inside, very straight, with a bit of anechoic fluid around it. So basically, this is a foreign body, and this is a pencil in someone's leg. So you want to make sure that you're not missing foreign bodies in all of your soft tissue scans as well. Any questions about cellulitis? Nope. So this is a 6-year-old female. She has a buttock and abdominal pain and swelling with erythema. When you examine her, she's got an 8 by 8 centimeter erythematous region that is fluctuant. She's otherwise not fever, does not have fevers. So here is what happens when you put the probe on. So what does this look like in comparison to the other ones we've seen previously? Abscess, perfect. So you're seeing a collection of fluids. So initially you're seeing some cobblestoning and hyperemia and soft tissue thickening. And then in the center, you're seeing this anechoic region with lots of septation. So this is an abscess. Abscesses can look like lots of different things. This one happens to be septated with internal contents, but they can be on a spectrum as well. So they can be just anechoic. They can have debris inside of them. They can have coalescing pockets. They can have septations, lots of different things. But you're right, this is an abscess. So this is something that you would want to consider INDing depending on the size. The size based on your key ruler on the side. So this one's roughly 1.5 by roughly 2. So fairly large. And the borders are not always well defined in this. So sometimes you'll see a very obvious round oval structure. This one you can't really pick exactly where it ends and exactly where it begins. All within the spectrum of normal. So we put flow. And this one, there is no flow exactly inside of it. So you know this is not a lymph node. Because sometimes it can actually be lymph nodes that are just infected instead. So you want to make sure you put flow on and there's no internal flow within. There's no vessels around it that you're going to cut into. So in terms of this patient, the white cell counts were elevated with the left shift, CRP was up, and the blood culture grew MSSA. This patient was IND'd and they had pus obtained. They were put on IV antibiotics and they were admitted to another hospital. Here's another example of an abscess. This one's a lot more, has more clear borders and a little bit more oval in shape. But what's different about this one when we put the flow on? What do you guys think that is?
There's a lot of flow.
There's a lot of flow, you're right. What do you think that is, Ben? There's a lot of flow right there.
A vessel down there.
It's a vessel right there. So that's something you want to cut?
No.
Nope. It's not something I feel comfortable cutting at all. So really important to put your flow on and make sure you know what you're cutting into before you cut.
But then could it be a pseudo-aneurysm?
Yeah, but it's not coming all the way up. Like, good thoughts, but I think it's not coming all the way into it. And an aneurysm would have flow through all of it.
Even if it's a bit thrombotic?
If it was thrombotic, then potentially no. This clinically was an abscess. No, but definitely good thought.
If any here knows Russ Horowitz, Russ is one of the POCUS gurus in Chicago. He was doing his fellowship when I was interviewing for fellowship, so he's kind of like that, a little bit more senior generation, so he's had a chance to accumulate even more stories. And he has this case that I'll show at conferences and teaching rounds about a kid with that received a soft tissue penetrating injury a couple months prior and had this ongoing draining abscess to their thigh, and came in because it was flared again, and so he was going to incise it, and it was clinically an abscess, and he had him in the back procedure room where there's like no monitors, and thought, come on, I'm a clinical ultrasound guy, maybe I'll get cool images. And so just for interest's sake, took a look, and it was this hugely pulsatile femoral artery pseudoaneurysm that he was about to jab a needle into. And it's one of those images you look at and you just go, oh God. Oh, God. Like we all would have been burned clinically by it. So certainly a good idea. Think of that.
So in terms of the evidence, there is a lot of evidence out there. I'm not going to go through all of it. There have been 2 meta-analyses that have come out in the last couple of years. So I'm going to go through those instead of going through all the RCTs and cases that have come through. So pardon me if I don't pronounce all the names properly, but Barbrick in 2017 and BMJ Open did a meta-analysis, and they looked at the POCUS accuracy of abscesses. So they had adults and pediatrics in this study in terms of what they were looking at, prospective cohort and case control studies, and they did a ped subgroup as well. So of all the 8 articles, 5 that they used, 5 of them were pediatrics, and they were all good to excellent quality. So overall, from a pediatric standpoint, the sensitivity was 94% to detecting abscess, and the specificity was 83%. In terms of changing management, so they looked at how often, when you looked, that you thought, hey, is this a cellulitis, and it turned out to be an abscess, or is this an abscess that turned out to be a cellulitis, and therefore did or did not need IND. So 14 to 27% of the time, it did change their management. So that's about a quarter of the time you're changing your management based on your scan, which is a large amount, especially when you're putting kids through painful procedures and sedation that they might not need. So definitely supports doing POCUS prior to doing any sort of IND on your cellulitis or abscess, but also to focusing when you think there isn't an abscess there, because really there might be, and you might need to change your management. In terms of basically the next one, I'm not going to try and pronounce that. In 2016, in Academic Emergency Medicine, there was another meta-analysis. They looked at POCUS versus clinical assessment of soft tissue infections. They excluded trials that were anything around the oral area or required surgical drainage in the OR. They had 6 observational studies, and 4 of them were pediatrics. Overall, they had a sensitivity of 97%, specificity of 83%, and positive likelihood ratio of 5.5, and negative likelihood ratio of 0.04. So POCUS overall is more accurate than clinical exam alone, especially they found when the exam was equivocal. So definitely important to support using POCUS in your soft tissue assessments. So overall tips and tricks for abscess. POCUS does change your management, so definitely consider picking up the probe and use your color Doppler to identify your surrounding structures. So avoid cutting into things like lymph nodes and vessels.